Hi everyone, welcome back to UWorld's Next Gen NCLEX Review. My name is Samantha. I am a nurse here at UWorld. Thank you so much for joining today. So in today's video, we're going to be looking at the differences between type 1 and type 2 diabetes mellitus. So if you've ever worked in the hospital or done a clinical in a hospital, you know that diabetes is prevalent on just about every floor in a hospital. Regardless of the clinical setting that you work in, you will most likely encounter a client with diabetes. Just about every shift I work as a bedside nurse, I give some form of insulin. So obviously a very, very important topic. Today we're going to have diabetes related questions sprinkled throughout today's video, as well as our NCLEX style questions at the end. So make sure you stay tuned for those. You don't want to miss them. A couple of housekeeping things before we get started. Follow us at UWorld Nursing so you don't miss any of these lectures or question drills moving forward. Also, let us know in the comments when you test or if you've already tested, so we can either congratulate you or wish you good luck. We always love to know where everyone is in their testing process. Again, so you know, this live will be on demand on all of our social channels, so you can always drop back in and use it as a future reference. Personally, I find our YouTube channel as our easiest channel to search. So whatever you're looking for, type in the search bar and go look at our live video on that. As always, drop your comments and questions into the chat. We have Nurse Jackie moderating today. So we want to hear from you guys. Let us know where you're joining us from. Let's get that chat started. And while y'all are dropping that into the chat, let's go ahead and start out with our hyperglycemia image and look at type 1 diabetes mellitus before we move on to type 2. So we know that type 1 diabetes is a chronic endocrine disorder. It's characterized by an absolute deficiency in insulin production, meaning the body is producing absolutely no insulin. And I'm going to ask you guys a question to get us started. I know we're already dropping where we're from into the chat, but also let us know the destruction of what organ is the cause for type 1 diabetes mellitus. So essentially, what organ is most closely involved in the pathology of type 1 diabetes mellitus? I'll give you a chance to go ahead and drop that in the chat. Also, we just got back from Seattle, where we were the sponsor of NSNA. This was such a phenomenal experience. If anyone is tuning in who was at NSNA, please say hi, let us know. We're so happy to have you here. At NSNA, we gave 8 hours of specific and targeted NCLEX review. We will also be offering this. We have 6 different sessions throughout the year. We've only completed 1 of those, so we have 5 more left to go. So if you're interested in these resources, go ahead and make sure you are subscribed to UWorld Nursing as well as the NSNA social media, because that way you'll be able to stay abreast of these topics and know when we plan these virtual webinars. Alrighty, I'm going to check the chat. And it looks like most of you guys are spot on the money. Way to go, you guys. So the pancreas, that indeed was the answer I was looking for. And I see someone, it looks like they're from Texas, saying, I was at the NSNA conference. It was great seeing y'all there. Thank you so much for joining. We're so happy to have you. Alrighty, so now that we've established the pancreas is the main organ that's involved, let's talk about the pathology here. So the etiology of diabetes type 1 is the autoimmune destruction of the beta cells in the pancreas. So that's why and how we see that pancreas so closely involved. Essentially, the purpose of insulin is it works to allow glucose into the cells of the body. Without this insulin, we can't meet the body's metabolic demands. We can't supply energy, that glucose, into the cell to allow the cell to do whatever job it's tasked to do. And we know those beta cells produce the insulin, so when we have that autoimmune destruction of the pancreatic beta cells, this is where the problem lies. So our clinical features, most often this will present in children and young adults. Typically, they'll present very, very thin, so this will make them be very thin. Our manifestations of diabetes mellitus type 1 mostly result from hyperglycemia, or that persistent state of high blood sugar. Clients with the hyperglycemia here will typically become symptomatic pretty quickly, and our notable symptoms will be weight loss, i.e. their thin presentation, and those 3 P's of diabetes. So another question for the chat, what are the 3 P's of diabetes? So we know they all start with P, and I'll give you a hint, they all start with poly, meaning increased blank. So if you can't get them all, no worries, just drop 1 in the chat. But let us know again, what are the 3 P's of diabetes? I already see one person answered polydipsia, absolutely, way to go. And I see Mercy on TikTok got them all correct. Polydipsia, polyphagia, and polyuria. Way to go, you guys, you are spot on. So these are indeed correct. Polyuria is going to be increased urination. Polydipsia is going to be increased thirst, and polyphagia is increased hunger. Another symptom can be the potential for ketoacidosis. So clients may actually present with this in a clinical setting, which is what's going to prompt their diagnosis of DM type 1. Ketoacidosis is an acid-base imbalance. We can see fruity breath in these clients as they blow off those ketones. We can also see those Kussmaul respirations, those really rapid respirations. Clients can present with blurred vision. They can also have something called nocturnal enuresis, which means they're up peeing all night long, and they're more likely to contract yeast infections. So management, what are we going to do for these clients? It's really important that they maintain a consistent meal and snack schedule. We want to make sure they balance their diet between protein, carbohydrates, and fat. We're trying to keep their blood sugar stable, so avoiding those really high peaks and those really low dips. And we do this by maintaining our intake. We're not eating a bunch up front and spiking that blood sugar and then not eating for a few hours and letting it dip down low. We want to make sure we keep it really tightly controlled and consistently eat our meals and have snacks in between. We want to maintain close monitoring of their blood sugar. This may look like frequent finger sticks to check that capillary blood glucose level. Nowadays, a lot of clients opt for that continuous glucose monitor, or the CGM. Many of these continuous glucose monitors will actually be compatible with smartphones, so maybe your iPhone, meaning you can actually monitor your glucose in real time via an app on your phone. So this is something that's really important. It's cool to see how far technology has taken us, especially in the medical sense. But regardless of whether or not they have these CGMs or they're just logging their blood sugars based on their capillary blood sugar sticks, it's so important to log these blood sugars so the provider can see where the client is hanging out, so to speak, because this will signify the need to potentially adjust the insulin regimen. Remember that clients with type 1 diabetes have that complete lack of endogenous insulin, meaning they will need lifelong insulin therapy because their body is not going to produce any naturally. So if we're not producing the endogenous insulin, we have to supplement with our exogenous insulin, meaning that insulin that we administer or the clients administer to themselves. So our insulin requirements really vacillate throughout the lifespan. Children and young adults have a higher metabolic demand because they're growing, so they're going to require more insulin than an older or maybe a sedentary counterpart. Another phase of life where our insulin requirements will really vacillate is pregnancy. So a client with type 1 diabetes who becomes pregnant will need to be followed by a reproductive endocrinologist to make sure we're staying tightly on top of what the insulin needs are and what those metabolic demands are going to be. All right, teaching. So teaching is so paramount in diabetes education. Type 1 diabetes is typically diagnosed in young children, young adults, so here education is really going to be paramount. It's important to note that the management of diabetes requires insulin administration, finger sticks, really around the clock monitoring, so depending on the age of this child or young adult, they may not be able to do this independently, meaning we may need to incorporate a parent or a caregiver to really help and make sure they maintain adherence to their insulin regimen and to their glucose monitoring needs. So key education points for our type 1 diabetic clients are going to include consuming extra food prior to exercise. So when we have an increased metabolic demand, like when we exercise, maybe we run, maybe we swim, maybe we play basketball, it's going to require more energy. So our rule of thumb is that we need 10 to 15 grams of carbohydrates for every 30 to 45 minutes of exercise. So while this client exercises, they need to monitor their blood glucose very closely. At the very minimum, it should be before, during, and after these periods of activity. When it comes to insulin injections, we also really want to make sure these clients rotate their injection sites. So when they get diagnosed, of course, they're going to be in a clinical setting. They need a little bit of help, a little bit of teaching. But when they go home, they're going to need to know how to do this independently. So we need to make sure we educate them to rotate the injection sites. This helps to prevent infection, swelling, as well as discomfort, but it also prevents the development of that scar tissue by rotating sites as opposed to using the same one every time. Our clients also need to carry a glucose tablet with them at all times. Now, this is in case of a hypoglycemic event. So most of what we talked about today has been hyperglycemia, that high blood sugar, but there's also a danger if we get hypoglycemic or we drop our blood sugar. So clients need to know to carry some glucose source, maybe a juice, maybe a glucose tab. They now have glucose gels as well. In the case of a hypoglycemic event, that blood sugar less than 70, so they can quickly eat some kind of glucose source and pop it back up to a safe range. Clients will need to wear a medical alert bracelet in the case of an emergency if they're unable to advocate for themselves and tell the medical provider that they do have diabetes. They also need to monitor their long-term control of blood glucose. Now, our finger sticks, that continuous glucose monitor, those are going to be short-term in the here and now checks of where our blood sugar stands, whereas something called hemoglobin A1C is checked about every 3 months. This is a longer-term measure of where our blood sugar has been for the past few months. So that finger stick tells us where we are right now. The hemoglobin A1C tells us where we have been, because we want to make sure over time we're keeping a tight control on that blood glucose. Now, also really important is sick day management. Our need for insulin actually increases while we're sick because the body's metabolic demand increases to fight off whatever sickness the client is battling. A lot of clients think, oh, I'm sick, I'm not doing much, I probably don't need my normal insulin, when in reality, when you're sick, you actually need more insulin in most cases. So it's important that we have that proclivity for hyperglycemia. We do not withhold insulin on sick days, and we make sure to monitor our blood glucose even more frequently to make sure we're not trending towards hyperglycemia. Alrighty, clients should also keep a spare insulin bottle or insulin source with them at all times, and they need to make sure to adhere to proper storing guidelines. Some insulins will be kept at room temperature, some need to be refrigerated. It's really important we make sure our client knows what to do with it before they go home. Again, it varies depending on the type of insulin. We also need to make sure we educate them on hypoglycemic events, again, that blood sugar under 70. Treatment will vary depending on their presentation, so a conscious and able to swallow client will be able to intake that quick-acting oral glucose that we talked about earlier. However, if a client presents unconscious or unable to swallow, we would have to rely on an injection, like an IM or intramuscular injection of glucagon, because we can't trust them to swallow something without aspirating if they're unconscious. Remember that hypoglycemia is a medical emergency, and treating it quickly is key to avoiding any injury from it. Alrighty, great job, you guys. So now we summed up our type 1 diabetes mellitus info. Let's move on and switch gears to type 2. Alrighty, so our pathophysiology here is a little bit different, but we have a lot of commonalities. So in type 2 diabetes, the body is either not producing enough insulin, or the insulin that is being produced is not having the desired effect on the body. It can also be a combination of both of these two things. The key difference here is in type 1 diabetes mellitus, which we just discussed, the body does not produce any endogenous insulin, whereas in type 2 diabetes, it's either not producing enough, or what's being produced is just not having the desired effect. Remember, the pancreas is still making some insulin in type 2 diabetes. So the cause of type 2 diabetes is a combination of different metabolic abnormalities. And these include, first, those pancreatic beta cells. Remember those from when we talked about it a few minutes ago. Insulin resistance and that inadequate insulin secretion typically occurs from these pancreatic beta cells. This is what contributes to that state of high blood sugar or hyperglycemia. And what it does is it creates a cycle of impaired metabolism. Essentially, the pancreas normally would respond to hyperglycemia in a healthy person by releasing more insulin. In type 2 diabetes mellitus, the pancreas is unable to do this because the beta cells of that pancreas end up fatiguing. They get tired and they can't keep up with the body's demand for insulin. Our second part of that abnormal metabolism, is the liver. So the liver is typically tasked with responding to the amount of glucose in the blood in a healthy person. It signals to the liver whether they need to produce more or less glucose. But in type 2 diabetes mellitus, we see impaired functioning of the liver, which usually leads to producing too much glucose, just another factor that contributes to that state of hyperglycemia. Alrighty, so our risk factors for type 2 diabetes mellitus. Let's check in on these. So we know we have our non-modifiable and our modifiable risk factors, simply being what we can't control and what we can control. So non-modifiable, these are things that we have no bearing over. Things like age greater than 45, obviously we can't control that, but it does make a client more likely to contract type 2 diabetes mellitus. Having a family history also makes a client more likely, as well as a history of gestational diabetes mellitus. We have a live on that. I think it's our maternal health live. So if you're curious about more info for gestational diabetes mellitus, please check that out. We have a great resource on that. And then we have our modifiable risk factors. So these are things that we have some bearing over. We can change or modify. Obesity, also a sedentary lifestyle. We can add in exercise. We can diet more. Hyperlipidemia is another contributing factor. Hypertension, again, that high blood pressure. And smoking. I feel like smoking is a risk factor for just about everything. All right, so our clinical features, what do these clients with type 2 diabetes mellitus present with? So it typically has an insidious onset, meaning it can take years to notice these symptoms in a lot of cases. Clients often live for years in a state of asymptomatic hyperglycemia. So they have this high blood sugar, but they don't have symptoms, so they don't get diagnosed. However, upon noticing the symptoms, our clinical features, our presenting features typically include, again, those 3 P's of diabetes: polyuria, polydipsia, and polyphagia. Again, increased urination, increased thirst, and increased hunger. Clients can present with vision changes like a blurry vision. We can see damage to the lenses of the eye, which typically manifests as a cataract-like vision change. Cataracts are the clouding of the lens of the eye. Now, our diagnostic criteria, our gold standard is going to be that hemoglobin A1C that we talked about earlier. So what would be diagnostic of type 2 diabetes mellitus is a hemoglobin A1C that's greater than or equal to 6.5%, which is measuring poor long-term blood glucose control over time. We can also do other things like a fasting glucose at or greater than 120 or a random glucose at or greater than 200 with the presence of those hyperglycemia symptoms being the 3 Ps can also be considered diagnostic. Alrighty. So now we're going to move on to our complications. So we have a diabetic ulcer image. It's a little gnarly, so if you're squeamish, maybe you might want to look away or just listen. But our complications from diabetes type 2 can be divided into our macrovascular and our microvascular complications. So macrovascular, thinking those big arteries, those big impacts, things like coronary artery disease. We can also see stroke. And we can see something called a TIA, which is a transient ischemic attack, which is something that's considered a warning sign of an impending stroke. Clients can also have peripheral artery disease, or PAD. And then we move on to our microvasculature. So those small blood vessels are small as capillaries. I had a professor in nursing school that said diabetes destroys microvasculature, and I think that's so true as you learn more about the pathology of this disease. So our microvascular complications can include peripheral neuropathy. Essentially, blood is unable to get to those smaller vessels that oxygenate and feed those nerves, which will lead to pain. We can see retinopathy. This, of course, affects the retina of the eye. We can see deterioration of that retina. And nephropathy, which affects the kidney, nephro like nephron, which is essentially the deterioration of kidney function. This can lead to chronic kidney disease, or CKD, and eventually progress into end-stage kidney disease, or ESKD. We just did a live on this about 2 weeks ago, so if you want to learn more about CKD, go ahead and head to our YouTube channel and check that out. Other complications from type 2 diabetes mellitus include delayed wound healing. Now, if you look at the ulcer, the image we have displayed, obviously this is a pretty big issue if we have the proclivity to develop these ulcers and then our wound healing is delayed. So we get these ulcers, but the body has a slow healing process. Obviously, this is really an opening in the body and a chance for subsequent infections. We can have recurrent infections because, again, bacteria and fungus, they love that high state of glucose or that hyperglycemia that is consistent with diabetes. Another complication is something called HHS. This is hyperosmolar hyperglycemic state, so super long name, but what this is a state that's life-threatening. Essentially, in this disorder, our blood will be concentrated, water is drawn out of the cells, which together equals some really severe dehydration. Clients will also add on to that dehydration because the body tries to excrete out a lot of that extra glucose, flush it out of the symptoms, so we see polyuria, which just adds on to our dehydration. This can have either an insidious or a gradual onset, and we can see some really high blood sugars here. So they can be above 600, so sky high. Our symptoms will a lot of times affect the neurological systems. We can see visual disturbances. Clients can see altered level of consciousness, even leading and ending up in a coma. Clients typically, the treatment here is given lots of fluid. Remember, they're very, very dehydrated. We, of course, need insulin to lower that blood sugar, and they'll need electrolyte replacement as needed. So our nursing intervention here, our type 2 diabetes mellitus nursing intervention is really going to have a big emphasis on teaching. We want to make sure we educate these clients. So the glucometer, they need to be able and be confident to test their capillary blood glucose. Maybe they have that CGM, that continuous monitor. Maybe they just do their finger sticks. We also need to educate them on necessary lifestyle changes. So exercise if they're sedentary, diet if they need to lose some weight, and avoiding alcohol is really important. The medications that will be used to manage this. Now, the difference between type 2 and type 1 diabetes is that we're always going to need to supplement in type 1 with that exogenous insulin, whereas in type 2, some of these type 2 diabetic clients can actually be managed just by oral medication. So some clients will be okay on something like a metformin. However, if this does not maintain our blood glucose in our desired range, we may need to add in an insulin. And in supplement, we also may give a statin to help treat some underlying hyperlipidemia, and clients may also need some antihypertensives if they have underlying hypertension. Clients need to be taught to monitor for signs of hyperglycemia and HSS, but also that hypoglycemia that we talked about earlier. And speaking of our diabetic foot ulcer, that proper foot care is so important. So these clients need to inspect their feet, inspect their toes, quickly report any signs of infection, ulcers, or skin breakdown. We also want to teach them to wash their feet with lukewarm water. Remember, they have that peripheral neuropathy, so they're not properly able to sense really hot or really cold water, essentially sense the temperature that would be damaging to their tissues. So in this case, we want to make sure they test water before they put their feet into it, and they really keep proper foot care and inspect their feet quickly or often. All right, sick days. So we also need to make sure we educate on sick day management. The main point here, as we previously talked about, is that insulin should always be continued during periods of sickness. Even if the client is resting, they're not very active while they're recovering from this virus or this bacterial infection, we need to make sure they keep a tight look on that blood glucose and they do not skip the insulin. Again, the body's metabolic demand will actually increase while a client is sick to work hard to fight off that infection or that virus. So clients need to know not to withhold their insulin. We can also make sure we educate them on the need for routine eye exams to check for that retinopathy that we talked about, and diet. Now this will be so important. Luckily they have lots of diabetes educators in hospitals now that do a lot of the dirty work with the diet and the carbohydrate count. We want to make sure we counsel them to have a high fiber, low fat, and low glycemic index diet. A few examples here of swaps we may want to make is that we want to encourage whole fruits rather than a dried fruit or a fruit juice because those have really high sugar content that's more concentrated. We also want to educate them on the need for lean proteins that are baked or grilled as opposed to fried and those really heavy fatty proteins. Alrighty, so that sums up our lecture material. Now we have a special 3 questions as opposed to our normal 2. So let's jump into our first question of the day. All right, the nurse is teaching the client with newly diagnosed type 1 diabetes mellitus how to manage their condition at home. Which of the following interventions should the nurse include in the client's plan of care? Select all that apply. Option 1 is teach the client to rotate injection sites when administering insulin. 2, instruct the client to limit oral intake if capillary blood glucose level is elevated. 3, remind the client that fruits and veggies do not need to be included when counting carbohydrates. 4, instruct the client to check the capillary blood glucose level before meals and at bedtime. And lastly, demonstrate to the client how to visually inspect the feet daily. So drop your answers in the chat. Again, we have a special 3 questions. We have a bonus question today. Alrighty, and in the meantime, if you haven't shared this live, no better time to share it when we're doing our questions, when we're testing our knowledge. Also, if you have not followed us yet, please follow us on whatever your preferred social channel is. We do these lives 5 times a week. We're giving out lots of great and free resources. So I want to make sure that you guys use everything that we're giving. Make sure you get the full value out of this. After all, we are here to help you. So keep following and also let us know what topics you want to see us present. We have some really special stuff planned coming up for Nurses Week, but in the meantime, I know we're hitting a lot of important topics, but please let us know what you want to see, how we can tailor it better to your needs and the topics that you want to see. All right, I'm going to check the chat. I see lots of answers. Great job, guys. And it looks like you guys got this absolutely spot on. So 1, 4, and 5 were our correct options here. We want to teach that client to rotate injection sites when administering insulin. We want to make sure we don't develop that scar tissue. We also want to prevent swelling, discomfort, and the potential for infection. Option 4, instruct the client to check capillary blood glucose before meals and at bedtime. This is describing AC and HS blood sugar checks. We would definitely want to check that before bedtime so we know we're covered throughout the night, but we also want to make sure we check it before meals. This is a really common time to give a sliding scale insulin, which of course depends on where our blood sugar stands, is how we know how much insulin to give. So we want to do those AC and HS checks. And lastly, demonstrate to the client how to visually inspect the feet daily. We know that proper foot care is so important. These clients have that proclivity for those diabetic foot ulcers. They also have peripheral neuropathy in a lot of cases, so they can't always adequately sense and feel damage to the foot, an ulcer, or maybe damage from water that was an incorrect temperature. So we do want to make sure they inspect their feet daily and they report any infection, ulcer, or any kind of changes to a provider very quickly. Alrighty, good job, you guys. Moving on to question number 2. So the nurses taught an adolescent client with newly diagnosed type 1 diabetes mellitus. Which of the following statements by the client would require follow-up? 1, this condition can be managed by following a prescribed diet. 2, I understand this condition is an autoimmune disorder. 3, this condition requires me to monitor my carbohydrate intake. And 4, I understand I will have this condition for the rest of my life. Drop those answers in the chat. Let us know what you all are thinking. Alrighty, and I saw one person was there at NSNA. If anyone else is watching, maybe you just joined, let us know if you were at NSNA in Seattle. Maybe you joined virtually, but let us know if you were there. Say hi, stop by. We'd love to see it. We had such a fabulous time, and we're so thankful for everyone who came in and bought tickets in our NCLEX review. We had over, I think, 900 people that showed up, so we were so excited to do that. Y'all were such great students. Thank you so much for joining. We're looking forward to fall NSNA, which is in Columbus, Ohio. And again, we have those virtual webinars for NSNA throughout the year. We have 5 more to do this year, so we better get working, right? Okie dokie, I see lots of answers coming in, and it looks like you guys are kind of split between 1 and 2. So let's go over these ones. Which of the following statements would require follow-up? And we're talking about that adolescent client with type 1 diabetes mellitus. So requires follow-up is a negatively worded question. It's looking for an incorrect action, or in this case, an incorrect statement. So option 1 is our correct answer because it's an incorrect statement that requires follow-up. This condition can be managed by following a prescribed diet. That is untrue. We can only control it by diet sometimes in type 2 diabetes mellitus. But remember, type 1 diabetes is going to be the complete lack of endogenous insulin, meaning that all of these clients are going to need some form of insulin supplementation. We cannot only manage it with a prescribed diet. We also need insulin. Therefore, this is incorrect and requires follow-up. 2, 3, and 4 are all correct statements. So I understand this condition is an autoimmune disorder. It is. It's the autoimmune destruction of the pancreatic beta cells. 3, this condition requires me to monitor my carbohydrate intake. It absolutely does. It helps us to dose our insulin. It helps us to avoid those really high peaks and those really low dips in our blood sugar. The goal here is to keep a consistent carbohydrate intake so we can closely control that blood glucose. And lastly, I understand I will have this condition for the rest of my life. Also true, there is currently no cure for diabetes, so clients who get diagnosed will have to deal with this for the rest of their lives. Alrighty. And I see someone asking some questions. Type 1 is autoimmune. Therefore, that's a correct statement, and it does not require follow-up. Alrighty, good job, you guys. So I'm going to move on to our final bonus question of the day. And here the nurse is screening clients for those at risk for developing influenza. Which of the following findings should the nurse recognize is a risk factor for influenza? Select all that apply. So we have consumes a plant-based diet, history of type 2 diabetes mellitus, resides in a long-term care facility, receives hemodialysis 3 times a week, and lastly, takes methotrexate for rheumatoid arthritis. This one's kind of asking you to apply what you've learned today in a broader sense. I know you guys are up for the challenge, but we know that we talked about, I guess I won't give that away yet. It's kind of hints, but I'll let you guys go ahead and drop your answers in the chats. Just to give you a little look at our schedule for the week, tomorrow we are back at 3 p.m. Central Standard Time with a legal and ethics question drill. And super exciting, we have a new time. Nurse Andrew will be going live at 7 p.m. With that same question drill. We're also going to be back on Thursday at 11 and 3 with a prioritization and delegation question drill. So keep an eye out for those. These are two really requested topics, especially that prioritization. So please join. Again, those are question drills, so those are all questions and no lecture material. Alrighty, I see lots of answers. And it looks like there's some variation of which one we include, but the bulk of the answers we're getting at are correct ones and avoiding our incorrect ones. So way to go, you guys. Our correct options here are 2, 3, 4, and 5. So 2, we know history of type 2 diabetes mellitus. Both types of diabetes will put you at a higher risk for developing infections. We know or viruses, bacteria and viruses and fungus love that high state of glucose. They love that persistent hyperglycemia that so many of our diabetic clients struggle with. So this is a risk factor. Also resides in a long-term care facility. This is true. It's the same reasoning that our kids in daycare and schools who are in really close proximity are also more likely to come down with the flu, is because it's much more communicable and easy to spread when you have lots of people in close proximity. Receives hemodialysis 3 times per week. It's another risk factor here. And lastly, methotrexate for rheumatoid arthritis. Methotrexate lowers our white blood cell count, which will make it harder to fight off infection. So this would also be a correct answer. Lastly, consumes a plant-based diet. This does not have a direct relation to developing the flu. I would just hope as long as they get enough protein, we're good to go, but not related to the flu as a risk factor. So again, 2, 3, 4, and 5 were our correct answers. Way to go, you guys. You did so well today. We're going to run a quick peek at our QBank. So for all of our users that have already purchased the product, here's how to get more questions based on adult endocrine issues. So if you want more questions that include diabetes, here is how you access them. And also it's a sneak peek for anyone who has not already purchased our product, so you can take a look at what part of our QBank looks like. Alrighty, so thank you so much. I hope this was helpful. Diabetes is such an important topic. It is so prevalent, especially in the US. For those of you who aim to work inpatient, hardly a day will go by where you won't give some form of insulin, but it's such an important topic for you guys to get a handle on for your own practice, but also, of course, for that NCLEX. So great job today. Thank you so much for joining. We will see you at 3 p.m. and 7 p.m. tomorrow. Thank you so much for joining.